Hello everyone and welcome to Healthline 3. I'm Terri Simmons. Today we're talking with Dr. Paul R. Stafford of Pierremont Cardiology with Willis-Knighton Health System. And we're talking about atrial fibrillation, commonly known as AFib. We'll be taking your calls throughout the show, and as a reminder, please make sure you're in a quiet room with your TV turned down low so we can make sure and hear your questions. And the number to call is 318-219-4569, and you'll see it at the bottom of your screen throughout the show. Thank you so much for joining us, Dr. Stafford.
It's a pleasure to be here.
So let's talk a little bit first what that is. What is AFib and how serious is it?
Atrial fibrillation is an irregular, generally fast heartbeat that comes from the top part of the heart, the atria. The atria can beat anywhere from 400, 600 beats a minute, but luckily we have a kind of a regulator that's built in that doesn't allow that rapid a heartbeat to go to the ventricles. But it certainly can be serious. You know, the biggest issue with atrial fibrillation by itself, it's not a life-threatening rhythm problem generally in people that are otherwise healthy, but in some people can be a higher risk for blood clots and strokes and some serious things.
Okay, and we talked about this earlier today too. How do we know that that's what's going on? And to call you? What feels irregular?
And the symptoms can vary. Most people, and there are people that are asymptomatic that don't feel anything at all. We have people that come in and just kind of feeling bad for a couple of weeks, and we'll do an EKG and find out that their heart rate's 160, 170, they're AFib, and didn't know it. Most people do have symptoms, however. That's typically palpitations, perception that the heart's racing, skipping, fluttering, sometimes dizziness, shortness of breath, fatigue, those types of things. Sometimes even more serious things, probably more so in people that have other comorbidities or other problems, and that can be angina type pain, heart failure symptoms, and even passing out.
Okay, and we talked about that too, about how is it diagnosed? You mentioned, is it only EKG, or were there other things that you do to specifically say?
Sometimes it can be diagnosed a number of ways. Sometimes people have just skips and flutters and their doctor puts a monitor on them. Sometimes it's from a monitor. Sometimes it's an EKG that may just be an incidental finding. They show up for a procedure and they're hooked up to a monitor and they find it. Some people pick it up. Their blood pressure monitors oftentimes can determine irregularity. And so blood pressure monitors can pick it up all the time. All the smart devices that are coming around, Fitbits and smart watches and all of that, all of those have apps that pick it up very frequently.
It's so interesting how much that has changed.
It is. That's changed quite a bit in the last few years.
Because I know that before they've sent us home with a monitor that you would strap around a certain area, and you would wear it the whole time, maybe for a 24-hour period or whatever the doctor liked, right? To monitor the heart.
Right, that's correct. And we have those monitors, Holter monitors, that are usually 24, 48 hours, and there are other monitors that we can wear that are, up to, several weeks in duration that you can wear those. And they're a lot easier than they used to be. Used to be several EKG wires hooked to a big box, and now it's generally just this little sticky patch that goes in the center, so much, much easier. Take a shower and
really
other things wearing the monitors now.
Right, so you can. It's easy to wear 24 hours a day and give you a really good reading.
Absolutely.
Yeah, and so then is that automatically fed back to you where you can do it, or when they come in, do you download information? How fast
it can work both ways. Most of the time, unless we're looking for something that we think might be life-threatening, but most of the time it's just when they bring it back, bring the monitor back. But there are types of monitors that'll send us some of these extended monitors that will send us alerts and send us a little sample of what's going on each day.
Okay, great. Well, I think we have a caller already.
Okay.
So, Marilyn, it's nice to have you. What is your question for Dr. Stafford?
All right. I have already had a bout with urithmia, and I'm on Multec, MULTAG, MULTAQ, and I do have COPD and emphysema. But recently, with this humidity so high, my breathing is just really, really stressed. And the only relief I get is my Advair, and then I do use Spiriva. But my heartbeat seems reasonable, 69 to 72, which is regular for me.
And what is your question? Are you wondering?
Well, what is it? The humidity causing this extreme? I mean, really, shortness of breath? Or is it couldn't be the urethma, could it? Because
it could be most of the time. Yeah, with what you've mentioned so far, and that's a very good question, we hear things like that all the time. Sometimes when you have shortness of breath and you have other problems like COPD, sometimes it's difficult to tell, well, which is it? Is it the atrial fibrillation? Is that flaring up? Or could it just be the COPD? The fact that it seems to be improved with the breathing treatments kind of tells us that it might be more related to the breathing problem. I think if your heart rate's reasonable and blood pressure is reasonable during that time, it's more likely to be related to the pulmonary problem, the COPD.
Well, then the question is, do I push through that or do I rest back? Of course, sometimes I'm forced to rest back, but I didn't know quite what to do. Push through it or rest back?
I think if the shortness of breath, I think if that's new for you, then I think getting that checked out would probably be a good idea. I think, and that can be done a number of ways. You can start with the primary care physician or the cardiologist that's prescribed the Multac could, have you wear a monitor or do an evaluation. Also, if you see a lung doctor for the COPD, then that might be somewhere to start as well.
Yes.
But I would definitely get it checked out, and I think any of those options are probably good options.
Okay. All right. I just kind of wanted to, but it's just been recent since that humidity level is so high. It really has gotten difficult.
Yeah.
But thank you very much for the information.
Oh,
Thank
certainly.
you.
Certainly.
Thank you for calling, Marilyn. We hope you feel better soon. Thanks again. I love it when they ask these great questions, so don't be afraid to call in. Chances are, whatever question, there's several people there wondering the same thing, so it's always nice to talk to somebody. And
yeah, oh sure, sure.
So is this something that you can live with? I know I got a text early from a friend of mine who says her husband, she goes, are you going to be talking about this today at noon? My husband has AFib. Is this just something that people live with? They know they have it and they monitor it?
It is, and it can, there's several different types of atrial fibrillation. There's one that we call paroxysmal. All that means is it comes and goes, and that's probably by far the most common cause that we see. There's a persistent type that means it comes and goes, but often lasts longer, and sometimes requires something, some type of intervention to get it back in the normal rhythm. Sometimes it's a medication or even shocking the heart back in the normal rhythm. And the last one is sometimes it's permanent, or what we used to call chronic atrial fibrillation. And those are the people that are in it all the time. Okay. And millions of people are in atrial fibrillation all the time. And as long as they're, you've addressed the risk of stroke and they're feeling fine and their heart rate is controlled, and then, like I say, millions of people live like that.
Wow. And are there different treatments according to the individual, or how is it treated? There are,
and with atrial fibrillation, the treatment is often very individualized. It's usually a stepwise fashion that we do. Just going through that way, I think the first step might be just rate control, where we give medications, typically beta blockers or calcium channel blockers. I won't get into the specifics of the actual medicines, but lower the heart rate. And if you get the heart rate under control and alleviate symptoms and they feel fine, then sometimes that's, besides addressing the stroke risk, sometimes you're done. That's all you need to do. I think the second step with treatment is what we would call rhythm control, and that's where we make an attempt to get you back in the normal rhythm and try to keep you in that rhythm. And that's usually using other antiarrhythmic medications, and so that seems to work well for a lot of people. Third thing is people that have atrial fibrillation that's a little stubborn and not wanting to respond to the other treatments. Sometimes more potent antiarrhythmic therapies are needed. Some of those carry with them some side effects, but they can be better at getting you back in the normal rhythm and keeping you there. And probably the fourth thing are the procedures that we do for treatment, and that's the ablations and things like that you hear a little bit about. Strangely enough, you would think that staying in the normal rhythm would, long term, would be the best, but in clinical trials going all the way back to a trial called the Affirm trial 20 plus years ago, there's looking at all four of those steps. There's really not a lot of difference in mortality, how long you live, or the risk of stroke. And some people look at that and think, well, if you have medicines that are better and you have these procedures, well, why do you worry about the first couple of things? And I think to address that, the more potent antiarrhythmic medicines are more likely to have side effects and especially long term. And these are medicines that people are going to be on long term, oftentimes lifelong. And so sometimes the side effect profile can be even worse than the problem that we're trying to treat.
Okay.
And ablations are great procedures, but they can, they carry with them a risk with the procedure, and they're not perfect. 60 to 70%, success rates with one procedure, and so, everybody's different.
Everybody's different, and
it's kind
good
of
to
a
remember
long-winded.
No, that's great. No, you mentioned several things that I want to talk about. First of all, ablation. You're right. We do hear that term a lot. What is that exactly for someone listening?
There's a couple different types of ablations. Typically, what people think of with atrial fibrillation ablations are AFib. Obviously, comes from the top chambers or the atria. More specifically, there are 4 veins that, as oxygenated blood is returned from the lungs, it gets dumped back in the left atrium by 4 pulmonary veins. Atrial fibrillation almost always comes from those 4 blood vessels that return blood to the heart. With an ablation using radio frequency energy, which is heat, and being heat, or sometimes even cryo or cold therapy, you eliminate that connection and you do what we call isolation of those pulmonary veins. And that's a procedure that can be fairly complicated and can take a couple of hours or so to do. There's another type of ablation that you used to use a lot years ago before we had neuroablations, and that was called an AV node ablation. Not that the terms mean much, but that's where you almost completely interrupt the electrical activity between the top of the heart and the bottom of the heart. And so the top chambers, they can beat as fast as they want, but the bottom chambers are kind of isolated. So that does require placement of a pacemaker, because usually when you cut off the electrical connection between the top and the bottom chambers kind of beat at a very slow rate. So usually a pacemaker is involved to keep a heart rate of 60 or 70 or so up.
Ah, that's interesting. So where exactly, is that where the pacemaker is placed? How does that work for people? I know it seems so common because a lot of people have them.
Oh, sure.
And so how does it exactly work while we've got you here? Like, where is it normally placed? How does it work really, other than just generally?
Yeah, and pacemakers are put in for lots of things besides atrial fibrillation. I mean, that's not one of the more common reasons we actually put them in. But just in general, pacemakers are usually placed through a vein, often on one side, more times on the left, sometimes on the right, depending on which hand, your handedness.
Oh.
But we find access to the vein that takes us back to the heart, and so we insert wires or leads into the heart using X-ray equipment and position those, and we make an incision up here under the collarbone that's usually just a few centimeters long, and the device itself that's connected to those wires goes under the skin up here. And there are newer pacemakers that actually don't have any leads or wires at all, and they're placed actually inside the heart. And they have 4 little fingers that grab the heart muscle, and so several types of pacemakers that are kind of all do the same function.
Yeah, that's really interesting, because I was just about to say, I bet even pacemakers, all of this has come such a long way.
Oh, absolutely.
It's just incredible.
Yep, they have come a long way.
It's just fascinating that you can put something in someone's heart and have it do what it's supposed to do to keep someone alive and healthy.
And most of the procedures are anywhere from 40 minutes to an hour. They have become easier and easier to do.
That's another thing that amazes me, how quickly and that you could have it happen and then go home, and the recovery isn't even, the adjustment. Is there a long time for people to adjust to having a pacemaker? Is it that much does their life change that much?
It's really not. The procedure itself is very low risk. I mean, there's less than a 1% risk of any kind of a bad complication really with the pacemaker. As far as the wound, the incision site, it's actually very small, so that's usually not an issue. The thing people don't like about a pacemaker is there are some limitations that you have for a few weeks afterwards. So you can't raise your arm, extend your arm, and usually can't drive for a few weeks.
Okay, and is that the reason you choose which side, the less used,
part
so
of it,
that they can use
that's absolutely right.
Okay. And I know a lot of people with anything want to go instantly to, some people like to go to cure. Can this be cured? Is there a cure for this? They even kind of go past treatment. They just want to know, is AFib something that you talk about in those terms? Can it be cured?
Atrial fibrillation is never, we don't use the terms cure with atrial fibrillation.
Right.
Once you have it, you almost always have it. Everyone's different. Some people after the initial treatment might go years and years and years without having any symptoms whatsoever. Some people, despite medications, seem to have problems that show up from time to time that are more often. Some people that have successes with ablations sometimes have very, very little atrial fibrillation, but usually not a cure.
Okay. And that's good to know, actually.
And they do require, most of the time, lifelong medications. Even
Yes.
after ablations, it still requires medications for stroke prevention.
Right. But there's so many treatments where you can, really what we want is the quality of life, even when someone asks if it can be cured. Really, they just really want to know, am I going to feel good? And so it's reassuring to not think of it in terms of cure. Just therapies and treatments and just really giving you your quality of life is really what's important. And so tell us a little bit about, let's talk about stroke, because this AFib, it doesn't always obviously lead to stroke. So are these something to talk about together, or are they two separate?
No, they are, and that's the biggest concern with atrial fibrillation. Like I said initially, that it's generally not a life-threatening rhythm problem, but that's the biggest thing that we worry about. Is there is just across the board, there's about a 5-fold increase in the likelihood of having a stroke. There's I won't bore you with details of the point system, but there's actually a point system that tells us who that has atrial fibrillation, who's at the highest risk of having a stroke. And that's generally it's people that have congestive heart failure, people that have high blood pressure. As we get older, if you're over 65, we know that the risk is higher. If you're over 75, the risk is even higher. Diabetes is one of the risk factors. Any previous stroke or TIA, what used to be called mini strokes, those carry with it a significant risk of stroke. And then anybody with any previous vascular disease, if you've had heart attack in the past, if you've had stents in your heart, blockages in your legs, things like that, those all put you at risk of having a stroke.
And we talk about that. We talk a lot of times with Healthline 3 on layering of things that can happen to you. You think you have this one disorder or this thing, and we think that's it, but then you get something else too. So that made me think about that. You may have had a stroke caused by something else, and then you can get AFib later? You can,
and the more common cause of strokes are just like heart attacks. It's from ischemic heart disease, where you have cholesterol-rich plaque that forms within vessels, and over time that narrows the vessels and reduces the blood flow to the brain. And those are by far the most common. I think the most latest information on strokes related to atrial fibrillation is about 1 in every 6 or 1 in every 7 is attributed to atrial fibrillation.
Okay. And we mentioned too, early this morning, we talked about it being 65 and over, but we also mentioned that you can have AFib at a younger age too. And we hear young people having strokes. I think it always surprises us when we find someone under the age of 65 who has a stroke, but it does happen. And maybe for our viewers watching, it's all ages. So if you have any questions.
Is. I mean, pediatricians have to deal with atrial fibrillation and strokes and things as well.
Really? Now, normally in a child, is that because it's something that's is it hereditary, or is there something you just might be born with, the way your heart is, or?
And with atrial fibrillation in younger patients, sometimes it has to do with congenital issues that they have. Sometimes there are accessory or extra pathways that connect the top to the bottom of the heart. Other conditions that make you more likely to have atrial fibrillation. Okay. And luckily they have pediatric cardiologists that know a lot more about those than we do.
Yeah, but it's nice for you to let us know, though, about roundabout, that there are not just 65 and older that have these kinds of problems. What if someone come in and talk to you? Is it good to bring a list of maybe times of day that they have felt it flutter more, what was going on in their life? I'm sure it's the whole picture that you look at. When they felt the flip-flop that you mentioned, was it after exercise? Was it during rest time? Is
Yeah.
it good for them to tell you different times of day that they're having it if they see a pattern?
It is, and I think that's very helpful if they're having a lot of symptoms. I think keeping a log, sometimes just like we have people keep a log of their blood pressure, I think when they have symptoms is also important. Sometimes that changes how we treat atrial fibrillation. Some people have episodes of atrial fibrillation when there's more stressors on the heart that act to increase the heart rate. If they're working out or really push themselves a little too far, they're working outdoors, they're dehydrated or something like that. At times when they have an infection or fever, those things can make it more likely to occur. Other people have atrial fibrillation more with slower heart rates. We call that vaguely mediated, for what that's worth. But that's just associated with slower heart rates, and they tend to have it more when they are at rest or when the heart rates, when they're in the normal rhythm, is on the low side. These symptoms that wake them up at night, and sometimes people with that variant can have atrial fibrillation triggered by drinking cold liquids and things like that.
And why is that? If you drink a cold liquid, what would that do to?
That can activate, there's part of the nervous system called the vagus nerve, and that can be activated and cause that. That can be a trigger for atrial fibrillation.
Okay.
In addition to numerous other things that can trigger it, like sleep apnea and too much caffeine. A lot of people drinking energy drinks these days, and nicotine, excess alcohol, thyroid overactive, infectious processes like we mentioned, all those things can certainly be triggered. Sleep apnea is one of the big ones that we talk about.
Oh, really?
And alcohol is it's more so in the binge drinking over a weekend or a holiday, things like that, not so much the person that comes home and pours a glass of wine before they sit down to watch Channel 3.
That's right. Thank you, doctor. So you mentioned sleep apnea. That's another thing that, so a lot of people have that too, and some people don't realize they have that. So tell some of the people, what are the symptoms of sleep apnea? If you haven't been diagnosed with that and then you don't realize that, what are some of the things to think about your sleep process when you have AFib?
Sleep apnea can vary. Sleep apnea, you always think of a very large, kind of an obese person with kind of a short stature, short neck, that type of thing. But sleep apnea can be anyone. It's sometimes loud snoring can be a trigger, but not always. There are people that snore very little or don't snore at all and have horrible sleep apnea. Other things can be daytime somnolence, where you're always tired if you happen to go home in the middle of the day and pick up a book or watch TV, and within a minute you're out. So daytime somnolence, waking up and you're just as tired as when you went to bed at night, waking up sleepy, that can be a sign. Of course, headaches and things like that. Sometimes people that are trying to lose weight can't lose weight, or issues with blood pressure. All those things can be related. And then sometimes it's a spouse or someone that witnesses it, not just the snoring, but just feeling like you stop breathing at night.
Yes, that's exactly what we hear a lot of times. Especially, it's good if your partner is there in the bed with you and can tell that you've stopped breathing, actually. Because what is the actual definition of sleep apnea? What is it really? We know the symptoms of snoring and not breathing. What causes that to stop? You stop breathing while you're sleeping. And
that's actually what it is. It's just apneic or episodes where you stop breathing in your sleep. There are a couple of different types. By far the most common are the obstructive types, and that has to do with the airway when you relax, that can block flow. There's something called central sleep apnea, and that's triggered by the brain, and a lot of neurologists and other sleep specialists treat that more. Both of those can be treated with and probably the mainstay is CPAP or BiPAP, or one of the masks that wear. But sleep studies are very easy. Some of the studies now in people that don't want to go to a sleep clinic, those can be done from home with a kit that's sent with easy cookbook instructions on how to do it. So it can be done at home.
That has come a long way too, then.
It really
because
has.
I know not too long ago where it was you did have to go somewhere and all of the nodes were hooked up to you and you had all of these wires, and then you're sleeping in a strange place and they just monitor you, watch you, and read what's going on as you try to drift off to sleep. It's really interesting that now you can do it from home.
And that's probably some of the hesitancy for people to agree to a sleep study. It's the procedure itself. It's having to go in and get hooked up to all the equipment like you mentioned. Sometimes I think they know that they have it, and they are concerned about masks and just wondering how well they tolerate it. But I think by far the majority of people, as soon as they are diagnosed and treatment has begun, then they wish they would have done it much sooner.
True, and I think too, don't be afraid to ask how far it's come. You might not know how easy it is now to be tested to find out about something, what the procedure is for treatment. So if you do feel like you have that, just ask. Go ahead. You can always decide to do it or not to do it.
Absolutely.
But even the testing now is so much easier and more comfortable than it used to be.
Yes, it really is.
Yeah. So if you have any kind of condition, just call. Just ask, because we have no idea what you've learned so far and how different it is now. And
that's true.
Yeah. So tell us about, we talked about if you have pain. Is it chest pain or abdominal pain? When is a good time to call the doctor if you have abdominal pain? Could that have something to do with AFib also?
Atrial fibrillation's pain is not one of the more common symptoms, but it certainly can be, especially people with very fast rates. More times than not, it can be chest pain. People that have other forms of heart disease, like coronary disease, where they've had blockages, sometimes that increased heart rate is like a stress test. You know, the heart rate is up, and so the demands of the heart is up when you have atrial fibrillation with that fast heartbeat, and you can develop chest pain related to that.
Okay. And we have had people ask before if shocking the heart is actually dangerous. At what point do you when you have to shock the heart, and is that dangerous to the heart?
It's a very, very safe procedure. And that's done a number of ways. Sometimes when people are diagnosed with atrial fibrillation, if they come in and they're having bad symptoms like low blood pressure, persistent shortness of breath, any sign of instability, sometimes that shock procedure can be done very quickly. Oftentimes that takes a special ultrasound to make sure there's not a clot in the heart already. But more times than not, once we get the heart rate controlled, if we feel like cardioversion or shocking the heart might be necessary, then you get started on a blood thinner for 3 or 4 weeks, and then the procedure itself. But it's very easy. You're hooked up, you're monitored, anesthesia comes by, and they give you usually propofol or medicine to put you out literally just for a few minutes. There's a patch on the front, a patch on the back, and as soon as you're out, we just push a button. People typically wake up wondering when we're going to start, and it's already over.
Once again, it's come so far, and we just have no idea until we get in your safe hands how quickly this is done, how concise it is to take care of us.
And that works in the vast majority of people. Probably 80% or more of cardioversions are successful.
Okay. So we have a couple more minutes.
Okay.
I could talk to you all day. We have a couple more minutes, maybe 2 minutes, but I want to ask you maybe what are some things that people can do to prevent stroke? Is it blood thinners? What other things can we do to stay healthy?
And strokes related to the other kind of strokes, from blockages or what we call ischemic strokes, you know, aspirin and the things that we do to prevent other forms of heart disease, you know, diet and exercise, controlling blood pressure, cholesterol, diabetes, not smoking, those things. Specifically stroke that's related to atrial fibrillation, aspirin really has no role there, but the mainstays, it used to always be Coumadin or warfarin. Now we have some new blood thinners called anticoagulants.
Okay.
And there's 4 of them that are on the market, and those are typically what we do now.
Okay.
For stroke prevention.
All right, that's wonderful. Good to know. Thank you so much for being here today, Dr. Stafford. It's been such a pleasure meeting you and answering so many questions. Just with the discussions, I know we'll be talking and one thing will come up and you'll answer it, and it's just really, I know all of our viewers really appreciate that. And we want to thank Marilyn too for calling in and asking such a great question. And we hope
it's my pleasure.
Yeah, we really enjoyed it. Is there any one thing you'd like to leave us with real quick?
Any question about symptoms, I think just seeing your physician and getting it checked out is always a good idea.
Okay, thanks very much. Everyone, thanks for joining us, and we'll see you next time on Healthline 3.